Okay, so here I'm going to talk about 19 questions, right? It's just musculoskeletal questions, anatomy and physiology. And I'm just going to talk about the breakdown of all of them. So the first thing, question 1 right here, is going to be a 42-year-old man administered a compound that eventually causes an inhibition of the enzyme phosphodiesterase. Okay. Inhibition of phosphodiesterase. As a result, the activity of which of the following enzymes, so what enzyme, is decreased? Okay, so we have an inhibition of phosphodiesterase, right? So inhibition of him causes another enzyme to what? Be decreased. Okay, so where is phosphodiesterase? Where is this used? Okay, so we use him for regulation of glycogen, right? In particular, glycogenolysis and glycogenesis. What are the differences between these two? So glycogenolysis is going to be the breakdown of glycogen, and glycogenesis is going to be the buildup, the storage, right? It makes glycogen. Okay. So I'm going to show two different charts now on the differences between glycogenolysis and glycogenesis. But first, let's think about the answer choices. So we have 5 choices. We have protein kinase A, phosphorylase kinase, phosphoglucomutase, glycogen synthase, or adenylyl cyclase. So all of these are used for glycogenolysis. However, one of them is going to be inhibited and one of them is not. So one's going to be active and one's not going to be active, right? Okay, so if we talk about that, then we could discuss the different types of enzymes that are going to be used. But first, we could rule one out. Which one could we rule out? We could rule out phosphoglucomutase. Why could we rule him out? Okay, so for glycogenolysis, we know glycogen is broken down, right? And then it's broken down with a glycogen phosphorylase. So glycogen phosphorylase is the enzyme. And then he's turned into glucose, 1-phosphate. Glucose 1-phosphate is then turned into glucose 6-phosphate using what enzyme? Phosphoglucomutase. Okay, so if we're already breaking down glycogen with enzyme glycogen phosphorylase and phosphoglucomutase, phosphodiesterase is not going to be used. So we could automatically already cancel him, like we don't need him. Okay, so now these 4 other enzymes we have a chance with, 25% shot. Okay, so here's the 2 charts. Chart 1 over here is going to be the regulation of glycogenolysis. Chart 2, this one, is going to be the regulation of glycogenesis. Okay, now, what do I mean here? So, for glycogenolysis, what is this? This is the breakdown of glycogen. And what do we want to use to break down glycogen? Glycogen phosphorylase. So we want this enzyme, well, technically we want this one to be active, right? Glycogen phosphorylase. We want him to be in his active form. Why? He will take glycogen and make glucose. Okay, so first, let's look for the phosphodiesterase. Here's the enzyme phosphodiesterase for glycogenolysis, and here's phosphodiesterase for glycogenesis. Now, we see ATP convert to CAMP to AMP, right? But before we discuss even further, we have to remember what's the goal here. The goal is to find something when phosphodiesterase is inhibited, right? What enzyme is going to decrease? So what enzyme out of all of these, this whole entire chart, is going to decrease? Okay. It's not as crazy as it looks. We'll break it down. ATP to CAMP, CAMP to AMP. CAMP, right, over here, gets broken down into protein kinase A. Protein kinase A does what? It's going to phosphorylate this ATP, become ADP. ADP is then going to go to phosphorylase kinase. Okay, when it becomes phosphorylase kinase, is it going to be in its active or inactive form? Well, you see right here it says active, but why? Okay, so if it gains a phosphate, right, if it gains this P, it's activated. Is this important? Is this phosphorylase kinase what we want? No. We want to stimulate glycogen phosphorylase. So it's a two-step process. So now another ATP molecule is going to come. It's going to react with this phosphorylase kinase over here, and he's going to give a phosphate to this glycogen phosphorylase. This glycogen phosphorylase now has a phosphate on it. What happens? He's in his active form. If he's in his active form, what is he doing? So I'm going to draw down here. Glycogen, right, is now being converted into glucose because he's breaking it down by this enzyme right here. This phosphorylase kinase is breaking down glycogen and making glucose. Okay, good. Now, say we're not fasting anymore, right? Or say, not fasting, I'm saying we have a meal, we eat. If we eat, our body's going to say, okay, we have enough glucose. Hold off, relax. How are we going to hold off? Okay, he's going to release our savior, insulin. Insulin is going to do what? So insulin, so say the food comes in our body, right? All these glucose molecules, right? Carbohydrates, etc. All these glucose molecules. Insulin is going to act like a big Pac-Man guy. What's he going to do? He's going to come and he's going to eat these glucose molecules, right? Not really going to eat it. He's going to carry them in to the bloodstream into the muscles or the liver. Okay? And this is how we're going to store our carbs. But before he does that, what does he have to do? Before he's allowed to get the glucose, right, into the body, we need to turn someone off. So who are we going to turn off? Okay. So how is insulin turned on? Insulin is activated from the food, right, or high levels of glucose. When he's turned on, he's going to activate protein phosphatase. What is this protein phosphatase going to do? He's going to travel up, right, and he's going to remove a phosphate. This phosphate is then going to remove glycogen phosphorylase. Or he's going to take the phosphate off of glycogen phosphorylase, and then this is going to become inactive. If he's inactive, what occurs? Okay, so there's nothing active for this phosphorylase kinase, right? Good. Now, insulin also is going to work right over here at protein phosphatase. Okay, if he's working at protein phosphatase, he's taking the phosphate off of this phosphorylase kinase and making this phosphorylase kinase inactive. So now we can't do anything to make more glycogen, right? We can't do anything to break down more glycogen. We need to store it. Okay, how does this occur? So if CAMP, right, this guy over here, if he's still active, he's going to keep releasing pKa. And if he keeps releasing pKa, we're going to keep breaking down ATP to ADP. So insulin has one other function. Insulin, right, he turns on phosphodiesterase. What is phosphodiesterase going to do? So this phosphodiesterase, right, he's going to come out and he's going to say, whoa, CAMP, right? Don't turn off, like, relax. Don't want you anymore. Okay, what's going to happen when he's turned off? Come back to glycogenesis, right? Because we're going to build glycogen. So phosphodiesterase, right, turned off CAMP. We're not building glycogen anymore, right? We're not building it. We're not breaking it down. Insulin stopped this process. He stopped this whole entire process. So if we're not breaking it down, we're going to start to build it. However, phosphodiesterase is what? He's inhibited. If he's inhibited, he can't, well, he's inhibited in our question stem. If he's inhibited, what's going to occur? Well, CAMP is not going to be turned off. That means protein kinase A is not going to be turned off, right? Well, if he's always turned on, he's going to keep making glycogen synthase. We don't want that. So in a normal state, like if PDE wasn't inhibiting, he's going to make glycogen synthase because he's turning off CAMP, right? Insulin is releasing this PDE, phosphodiesterase. This phosphodiesterase comes up, right? Turns off CAMP. Then this phosphatase over here can make glycogen synthase. It can make it active. And what is this glycogen synthase going to do? It's going to take this glucose from Mr. Pac-Man, and he's going to make new glycogen. Okay, now, what enzyme is inhibited or he's not working as correctly? It's going to be glycogen synthase. This is going to be the answer. Why is he the answer? Because PDE is inhibited. PDE is inhibited. CAMP is not inhibited. pKa is not inhibited. So they're making this guy. If they keep making an inactive form of glycogen synthase, they're not making an active form of glycogen synthase. So we're going to have a decrease in glycogen synthesis. Now, are we going to have a decrease in protein kinase A? No. Why not? Well, protein kinase A over here, right? He only decreases when PDE is activated. If he's activated, CAMP turns off, and if CAMP turns off, protein kinase A turns off. So he's not even going to be inhibited. What about phosphorylase kinase? Is he going to be inhibited? No. We said over here, if insulin's on, right, he turns on PDE. This PDE turns off glycogen phosphorylase. Okay. Well, if he turns on glycogen phosphorylase, what's going to occur? This inactive form is then going to be converted back down, and phosphorylase kinase is going to be active, right? Well, he'll be inactive if we turn off PDE. Okay. So is phosphorylase kinase going to be decreased? No. He's going to be increased. He's not going to be increased. Nothing's going to happen to him because we can't turn off this glycogen phosphorylase using PDE. So he'll be normal. Adenylocyclase. Adenylocyclase is the same thing as CAMP. Okay, so same scenario. If PDE can turn off CAMP, he's obviously not going to be decreased. So adenylocyclase is not going to be decreased. So the only answer that you could get is glycogen synthase. Okay, that was a long one. The other ones aren't going to be that bad. Okay, number 2. A 40-year-old male falls from a horse with an injury to the leg. Okay, he falls off his horse, injures his leg. He is referred to the diagnostic imaging department. Okay, so this means he's going to get an MRI probably or an X-ray, something like that, right? He's going to get an image. What type of image? Okay, frontal and lateral radiographs of his lower limb show a complete fracture all the way through the distal shaft with 90 degrees of lateral angulation. Okay, what does this mean? So let's break down the first part first. Okay, so there's going to be a complete fracture through the distal tibial shaft. What is that? So we have the tibia, right? This is the tibia. And this is going to be the fibula. This is a really not too good of a drawing, but I'm trying. Okay, so what's the fracture going to be? Through the distal tibial shaft, so deep down, right, far away. Not proximal would be up here. Proximal. This is going to be distal, so the distal tibial shaft, right, with 90 degrees of lateral angulation. So lateral angulation is going to be an angle, right? A 90-degree angle, so something like that. Okay, so where is this going to be? He's going to have an angle like that, right? A 90-degree angle coming across. Okay, so the lateral projection of the leg has the ankle appearing as a frontal projection. Okay, so this lateral side, let me delete this, right? This lateral side is now going to appear like it's in the front. So something had a twist. This bone had a twist somewhere. Okay, let's keep going. There's also a fracture of the proximal fibular shaft. Let's see if you could read that. Proximal fibular shaft that looks like a corkscrew. Oh, okay, that's it. We could stop right there technically. If you see this word right here, that's it. A corkscrew with a mild lateral displacement. Okay, so if there's a corkscrew, it's like a little spiral, right? If you see that word, that's the answer. Well, here are your choices. Comminuted, green stick, oblique, spiral, or transverse. Okay, but we saw corkscrew, so we know this is our answer. We know spiral is the answer. Now, before I go on, let's just talk about a couple of different fractures real quick. So we could take him out, right? Can erase this. Now, the first one, what's a comminuted fracture? Okay, so let me try to draw a bone right here. No, it's not good. Okay, let's do that. It's a humerus. Okay. If this is a comminuted fracture, it's like crack, like almost like getting destroyed. The bone is like rupturing, right, into a lot of different fragments. So this is a comminuted fracture. A bunch of different fragmented bone pieces right here. Bunch of bone chips, right? Okay, what's a green stick fracture now? A green stick fracture, the bone, let me try to draw it again, a new bone. The bone is going to break probably at the midpoint, right? Maybe to the proximal end, but it's going to bend first. So the bone is actually going to appear a little bent, and then he's going to fracture at the bent region. That's going to be a green stick fracture. Okay, now what about an oblique fracture? An oblique fracture is going to be a full-on fracture, basically, that cuts across the entire bone. This is going to be an oblique fracture going across. We spoke about spiral fracture, so the last one I want to discuss is the transverse fracture. What is a transverse fracture? This is going to be a fracture, right, that transversely crosses the bone. So he just goes directly across. Oblique, remember, goes on an angle, like this. Transverse goes right across. Okay, so those are the different types of fractures in the question stem. So now, question 3. A 1-month-old infant presents with upper respiratory infections. So upper respiratory infections. Okay. No evidence of thymus and some uncertainty regarding the location of parathyroid tissue is present. Okay. So there's no evidence of the thymus and some uncertainty regarding the location of the parathyroid tissue. Okay. Which of the following pharyngeal pouches, so let's highlight that, is important, were most likely affected in the clinical scenario? So, if you remember, what are the pharyngeal pouches? Okay, we have 4 of them, right? The pouches. And pouches come from where? Ecto, endo, or endoderm. This is the endoderm derivatives. Okay, so if they're coming from the endoderm. Now, we have pouch 1, 2, 3, and 4, right? 5 fleas, and 6, I don't think we even have a pouch for. So 1 is going to form the middle ear. We spoke about that. 2 is going to form the Palatine Tonsils. Okay. 1 is the middle ear canal, I'm sorry. Okay. 2 is the Palatine Tonsils. 3 now, this is where it gets very important. 3 forms the parathyroid hormone, inferior part, and the thymus. Okay. And what does 4 form? 4 also forms the parathyroid hormone. Okay, so let's look at the answer choices before we answer. First and second pouch. Definitely not, because that has nothing to do with the thymus or parathyroid, which is in the question, right? It said parathyroid tissue or thymus. So that's definitely not right. Now, second or third pouches. Well, it has second in it, so second's wrong, so that one's definitely wrong. Third pouch, maybe. So we're going to question him. Third and fourth pouches, maybe. Fourth pouch, maybe. Because it says parathyroid. Okay, so now, upper respiratory infections. If you don't know anything about them, it's fine. You can still answer this question. Thymus. So no evidence of thymus. Okay, so what does this mean? There's no evidence of a thymus. And some uncertainty regarding the location of the parathyroid tissue. Where was the parathyroid tissue? Parathyroid tissue can be inferior or superior, right? It switches during development. They flip-flop, right? They join together. So when they join together, the thymus comes below. But that's not really too important in answering this question. I just think that's like a interesting fact that would help. What else is important, however, is that it says no evidence of the thymus. So that means the thymus isn't there. What's going to occur then? What pouch is going to be inhibited or affected? The third pouch. So the third and fourth pouches, that's going to be wrong because it has fourth pouches in it. Fourth pouch is going to be wrong. The only answer could be the third pouch because this is the one that says the thymus is inhibited. Not having a thymus is going to cause upper respiratory infections. Okay. Okay, to continue, question number 4. What is question number 4 asking? While examining the neonate, the neonologist observed an underdeveloped mandible, cleft palate, and ear abnormalities. Okay, before you even continue, you should just high alert cleft palate. Okay, if I see cleft palate, I know this is probably going to be a certain arch. I'll talk about it in a little bit. But just know cleft palate is very important. Okay. Which of the following pharyngeal arches... Okay, so I just said arch. I gave it away. It's going to be which one of the pharyngeal arches most likely is affected in this scenario. Okay, so we're going to talk about an arch. And what are the arches? Where do they come from? Ecto, endo, or mesoderm? They're coming from the mesoderm. And how many of them do we have? I have 5. We have 1, 2, 3, 4, 5 fleas, and 6. So 4 and 6 are kind of together now. 4 and 6 are kind of together. Okay, what's going to happen with number 1? Well, each of them form a nerve, so we could talk about the nerves real quick. 1 is going to be the trigeminal nerve. 2 is going to be the facial nerve. 3 is going to be the glossopharyngeal. And 4 and 6 is going to be the vagus nerve. Okay. So if you don't know the different breakdowns, this question might be a little tough. But if you know them, it's very easy. So we have to know trigeminal is cranial nerve 5, and tri for 3, meaning it breaks down into 3 different regions. What are the regions? It could be V1, V2, or V3. That's a 4. V3. Okay, and we know it's oculomotor is V1. What is V2? Maxillary. And what is V3? Mandibular. Okay. So mandibular, this is the only motor nerve for the trigeminal branch. These 2 are sensory. Okay, but let's keep going. Facial is for the face. Face what though? Facial expressions. So it's going to move the facial expressions. The muscles that help you smile, frown, etc. Glossopharyngeal. This is going to be for the pharynx and the tongue. And then vagus, it's going to be for parasympathetic, heart, etc. Okay, but this is not what they're even asking. They're asking for an underdeveloped mandible, cleft palate, and ear abnormalities. So, what could we know about layer 1? 1 is going to form a couple different structures. The bones is going to be the ossicles, so that's ear bones, okay? And it's going to be the incus and malleus, right? He's also going to form the bones for the skull and the face. The bones for them. Okay. Number 2 is going to form the ossicles too, but it's going to form just the stapes. Okay. 3 is going to be glossopharyngeal. He's just going to form the lower body of the hyoid. And number 4 is just going to form the larynx and laryngeal muscles. Okay, so has this helped us with our answer choice? No, but it helped us eliminate a couple of things. What did it help us eliminate? Well, it's talking about a mandible, a cleft palate, and ear abnormalities, right? So larynx or laryngeal muscles wouldn't be in there. And then pharynx or tongue with the lower body of the hyoid is not going to be there. I mean, if you think cleft palate and tongue or mandible go together, that's one possibility, but not really. So you could cross these out. So 3, 4, and 6 could be crossed out. So 6, gone. 4th and 6th, gone. 3rd, no, we just said that. And 4th, no, we just said 3, 4, and 6 are out, so they're gone. 2nd only, maybe. 1st and 2nd, maybe, right? Because we only eliminated 2 so far. Okay, so if we keep proceeding down, the ossicles of the inner ear, the ossicles of the inner ear. Okay, so this is not going to help us with ear abnormalities, right? So ear abnormalities, we can't really make a decision based on that because 1 and 2 both have it. So we're not going to differentiate. It could aid us in picking the answer choice where it says 1st and 2nd. It's too big. 1st and 2nd, but we're just going to hold off on that for now. Now, the bones of the face and the skull coming from the first one, right? Arch 1. So it's also going to have neural crest cells. And then there's a whole process on how the neural crest cells deviate into the nose and then the upper lip bones and the mandible. I have a YouTube video on that, on how this whole entire jaw, that's not a jaw, on the nose and the upper lips and the jaw form. But I'm not going to go too deep, like detailed with that right here, but I'm just going to say, with these neural crest cells, we also help form the cleft palate. So, not cleft palate, it forms the palate. Okay, so if we form the palate, right, over here. Number 2, we just form the facial muscles. And we don't really form the bones of the face because that was trigeminal, or arch 1, I'm sorry. So, okay. We also see that we have mandibular, one of the nerves. So, if something's wrong with the face bone, one of them being mandibular, okay, this should ring a bell, mandibular nerve. And then we have cleft palate. We said cleft palate comes from a disorder in the development with the neural crest cells forming the palate. We know it's coming from the first arch, but it also said ear abnormalities. Well, ossicles, right? This is part of the ear bones. Incus and malleus, they could be affected. It doesn't mean all 3 have to be affected. If all 3 were affected, then yeah, we would have to say arch 2, because this would be the 3rd bone in the inner ear, but it only said some abnormalities. So we could eliminate choice 2, facial. We could eliminate 3, 4, and 6. So the only answer is the first arch. Never mind. So now, it said we could, let me take it from the top here. Okay, so we would be able to eliminate that, but what does the question stem say? So we have underdeveloped mandible, so boom. What do we have? Arch 1. Okay, so that's going to be a defect. We're going to have cleft palate, boom, arch 1. And we're going to have some ear abnormalities, so that's also arch 1. What other arch can he be? Well, he could also be arch 2, right? Second arch, because we have the ossicles and the stapes. So let's go back to the answer choices. Can it be second only? Well, it can't be the second only because it needs to have to do with the palate. So we need to do cleft palate, and we need to do an underdeveloped mandible, so that's wrong. But the only answer choice is going to be first and second, because why? We said mandibular abnormalities, we said cleft palate, and we said ear abnormalities. Okay, so that's number 4. Number 5. An obese 50-year-old woman visits her physician with a complaint of a painful lump in her proximal thigh. Okay, so we know there's a bump in her proximal thigh. So where's that going to be? Well, if this is the leg, the whole leg. This is the knee. This is the other leg. I'm not an artist. Here's the other leg, right? So proximal thigh is going to be up here. Proximal. And then this is going to be distal. Okay. Just medial to the femoral vessels. Okay, so medial, we know it's going to be on the medial side of the femoral vessels. So we know the femoral vessels run through the leg. So we're going to draw them here and in here, right? So it's going to be on this side, medial to them. The physical examination reveals a swelling is below the inguinal ligament, through which of the following openings has the hernia passed to enter her thigh. Okay, so we have to break this down now. What is below the inguinal ligament? So I have a couple pictures. So if we see up here, right, this is the inguinal ligament. If you keep proceeding down, what are you going to have? Okay, well, same here, inguinal ligament, right? Inguinal ligament over here. If you proceed down, you're going to have the femoral ring. Okay, so you know femoral ring could be an option. What else can you have? Inguinal ligament? Probably not, because it's below it. Deep inguinal ring? No, because it's got to be below it. Superficial inguinal ring? No, because we said it's got to be below it. Okay, so if we go to the answers, deep inguinal ring we already crossed off. Superficial inguinal ring we already crossed off. Now we have femoral ring, fossa-ovalis, or obturator canal. Fossa-ovalis, this is in the heart, so this is wrong. So now we're between the obturator canal and the femoral ring. Let's go back. Where is the obturator canal? Well, the obturator canal is like right over here, right? However, you're going to have a lot of cartilage and like nerves and stuff flowing through this passageway. Is there anything going to be wrong with like the muscle or anything like that to form a hernia in this region? Most likely not. The region that's going to form the hernia is going to be the femoral region, right? Right where the femur is going to be. So this is going to be right in the femoral ring. This femoral ring is going to form the hernia. So it's not going to be obturator canal. We just said that. It's going to be femoral ring. Okay, so number 6. 52-year-old construction worker injures his knee while on the job. Okay. Physical examination reveals that he's unable to unlock the knee. Unlock, what does this mean? Okay. When it is in full extension. Okay. Which of the following muscles is most likely involved in this instance? Oh boy. Okay, not too bad. Let me draw the leg again, right? I'm going to draw the kneecap, foot. That's extended knee, right? Let me draw the leg again. Let me try to draw a flexed leg. That's a flexed one, right? Okay. So it's going to be in the muscle of the knee, right? So it's going to be behind. So we're going to have a muscle back here. And we're going to have a muscle back here because it has to do something with where? The knee. And it's unlocking the knee. Okay, so if we go through the orders, 1, 2, 3, 4, 5, the answer choices, we have adductor magnus. Well, adductor magnus is going to do what? Here's another picture of the leg, right? Here's the knee, I guess. No, that's bad. So whole leg, right? The medial side is going to be the adductor magnus. So he's going to adduct the leg. He's going to bring it back to the middle of the body. Is he going to be by the knee? No, he's going to be like up here. So adductor magnus is not going to be the right answer. So you know that's wrong. Now, gastrocnemius. Where is he going to be? Well, he's going to be down by the calves, right? We know we have this heart-shaped muscle by the calf. It is one of the calf muscles, that and the soleus. If he's down by the calves and he contracts, right? Is he doing anything to this knee? No. He's doing what? He's aiding in plantar flexion of the foot. So you know he's wrong. Popliteus muscle? Maybe. Short head of the biceps femoris muscle. Well, what is he? He's on the posterior side of the leg. So if we draw another leg, right? Try to draw a little 3D, maybe. That's a foot going that way, right? This is the back of the leg up top. We have the short head of the biceps femoris. Well, what does he do? Well, he helps to extend the leg, right? Extend the knee, I'm sorry. Flex the knee. He aids to flex the knee because he's posterior. If he aids to flex the knee, he might have something to do with unlocking it, but I don't know. And what about the vastus lateralis muscle? Well, if we take another leg, I'm going to draw another leg picture up here. If this is the thigh region, right? And then you got the kneecap down to the lower leg. The vastus lateralis is where? Well, you have the quadriceps femoris, the 4 muscles here. And you have the rec fem, the medialis, lateralis, and underneath is the vastus intermedius. The vastus lateralis is going to extend, and he's going to connect to the patellar tendon. All he's going to do is aid in extension of the knee. So that's nothing to do with unlocking because the knee's already extended. So we're left with 2 choices. Short head of the biceps femoris or popliteus muscle. So the popliteus muscle is actually going to be the answer because he aids in unlocking the knee. Short head of the biceps femoris is just going to help with flexion of the knee. He's not going to unlock it. But I want to talk about how it unlocks. So here's a little diagram. When the knee is extended, right, this popliteus muscle helps rotate the knee to unlock it. This is the diagram that I've been using to help myself. It's my own little drawing. So it's going to be like this, right? This is going to be the back of the knee. Let's see, back of the knee, a little kneecap, right? You don't even need a kneecap for the back, but just bear with me, right? Okay, and then this is the little fibula. Okay, so the way I'm thinking of it, the knee is fully extended, right? A key, like a lock-in key, right? A key comes here. I don't even know how to draw a key. That's not good. Okay, a key, right? A pin, better yet, let's draw a pin. A pin enters into the back of the leg. So now the leg is locked, right? But what wants to occur? Well, the leg wants to bend. Can the leg bend if there's a pin running between it? No. So this pin's got to be pulled out. So the popliteus has got to pull out, right? And what's going to have to happen? Well, when he gets pulled out, the leg can flex at the knee. That's a bad foot. The leg could flex at the knee. So when the pin's in, as in the popliteus muscle, he's in, leg is extended. Pin's pulled out, he comes out, the leg could flex. So that's how I remember the popliteus muscle, like a lock and key. Okay. Okay, so question number 7 now. What is it saying? A 59-year-old woman was presented to the ER after an accident. Okay. Physical examination revealed foot drop. Okay, boom. If we know this, we should know this clinical symptom, clinical sign. Automatically, we should know the answer. But if you don't, we could still break it down. The patient was also had weakened dorsiflexion and eversion. Okay, so dorsiflexion and eversion. Which of the following nerves, so we're looking for a nerve, is most likely involved? Okay, so what is foot drop? So if we have our leg, right, body, and that's the foot, right? This is the foot region. Okay, so the foot is dropped. Okay, and he's also, what? It says everted. So eversion and dorsiflexion is weakened. So he can't evert or dorsiflex. So he's just straight down, right? The foot's pointing straight down. It's a better picture. Yeah, it's bad too. Whatever. Okay, so you have foot drop. Now, what causes this? Okay, so if you have a healthy leg, right? You're going to draw a nice, healthy foot. In order to go up, right, you're going to do what? Dorsiflexion. To go down, you're going to do plantar flexion. Okay, so if you're going to go inwards like that, I guess that's the best way I could draw it. That's going to be called inversion. And if you're going to go outward, so lateral, you're going to do eversion. Okay, so we need to find a nerve, right, that stimulates a certain muscle that's going to do what? That's going to damage dorsiflexion and eversion functions. Okay, so let's make a new picture, a little new diagram. What muscles dorsiflex the foot? So muscles that lift them up. That's going to be the muscles that come from the peroneal side. The muscles that plantar flex the foot is going to be from the tibial side. So peroneal is fibular and tibia is tibial. Okay, so number 1, the common fibular nerve. Okay, maybe. Deep fibular nerve, maybe. Femoral nerve. Well, that's wrong. Why is this wrong? Where does the femoral nerve come from? The femoral nerve, here's the kneecap, right? We proceed down, little foot. What is the femoral nerve going to do? Well, the femoral nerve is going to be in the femur, right? And he's going to stimulate the quadriceps femoris, the sartorius muscle that comes across, and then the pectineus. So femoral is going to be wrong because it has nothing to do with dorsiflexion or eversion. So we could cross him out. So then we could say superficial fibular nerve, maybe. Or what about tibial nerve? Well, you could cross him off too, because didn't we say that tibial nerve does plantar flexion? So if you're doing plantar flexion, that means you're going down, and we don't have a problem with plantar flexion. We have a problem with dorsiflexion over here. Okay, so we could eliminate 2 choices so far. So now, what do we have left? We have common fibular, deep fibular, or superficial fibular. Okay, there's a couple different ways to break this down, and there's a lot of different different thoughts that you could have. So what I would do, or how I think about it, is I'll start from the top. Superficial, obviously, right? So if you start on the top of the leg, I'm going to draw another leg here, and I'm just without a foot for now. So just straight down, right? This is straight down. Lateral, medial. Okay, so if we're going straight down, and we could see lateral and medial side, we know a couple things. Well, the common fibular nerve is the first one. So he's going to be up here, right? And he's going to branch into 2 different things. He's going to branch into the superficial fibular nerve, and he's also going to branch into the deep fibular nerve. Okay, so he has a couple functions. Superficial fibular nerve, what is he going to do? The superficial fibular nerve is really only responsible for 2 muscles, and it's the fibularis longus and the fibularis brevis. So where do those 2 muscles go? So if they're on the fibular side, they're on the lateral side, right? And if they're on the lateral, let me draw like toes. If they're on the lateral side of the foot, they're going to help with what? They're going to help, they cross it. So it's kind of hard to explain, but they're going to cross the foot, and they're going to help with inversion. So the superficial fibular nerve is going to help with, no, I was right. I'm sorry. What is he going to help with? He's on the lateral side of the foot. The superficial fibular nerve is coming down the lateral side of the foot, so he's going to help with eversion. So he's going to help with eversion of the foot. Okay. So do we have a weakened eversion? Yeah, so that's possible. This could be an answer choice because it's weakened eversion. But we're talking about dorsiflexion too. Does he dorsiflex? No. So we could eliminate him, but we're just going to put a question mark next to it. What's the next nerve? Okay, if we proceed down, we have the deep fibular nerve, right? We talked about the deep fibular nerve branching from the common fibular nerve. And what does he do? The deep fibular nerve really supplies innervation to the tibialis anterior, and he also supplies innervation to the extensor hallucis longus and the extensor digitorum longus. So what do these guys do? Well, they come down by the big toe because it's the hallucis, and they help with dorsiflexion. Okay, so dorsiflexion possible, but since it's by the big toe, what's it going to do? It's going to cause inversion. So that's automatically wrong. If it's inversion, you know that's wrong. Okay, so we have to go to the last one. We have to go to the common fibular nerve, also known as the peroneal nerve, right? Okay, that's how we're going to decide between this A or D. Okay, so common fibular nerve. What does he do? He branches down into these two different regions, but he also aids with certain movements. So he's going to go around the lateral fibular neck, right? And he's going to aid with all the different muscles, and these muscles, their main function, they're going to be dorsiflexion. So, okay, so we're going to dorsiflex the foot. We're going to go up, right? We're going to evert. So if we're going to do eversion, this way. And it's also going to do a little bit of inversion, but the majority of it is going to be eversion and dorsiflexion. So the common fibular nerve is going to be our answer here. Superficial fibular nerve only does eversion, so he's wrong. And then the common, I erased it all, I'm sorry. The deep fibular nerve, over here, he does inversion, but we don't want to do inversion. We need to do eversion. So that's how I broke down that question. I know it was a lot, but, I thought it was the best way to, talk about it. Okay, so number 7 is A. Number 8. What is number 8? A 15-year-old adolescent boy suffers a skateboard accident while showing off. Okay, so I don't know why I underlined that, but a skateboard accident when he's showing off. Okay, examination reveals a sagging left pelvis or dips, right? Sagging left pelvis or dips when he places his weight on the right leg. So something's wrong when he places his leg on the right leg. Which of the following muscle is responsible for the presentation? So whenever I see sagging of a pelvis, right, I automatically think of Trendelenburg sign. Okay, so we know Trendelenburg sign is what I'm thinking of. Let's break it down real quick. So I'm going to draw posterior legs, right? This is going to be one leg and the hip kind of, I don't know. This is going to be another leg and the hip, right? So the hip is going to be up here. Those are the bones, I guess. Try to visualize it. This is the back of the knee. Okay, so if that's the hip. So now, if the person's walking, right, and we say he has a sagging left pelvis. So this pelvis, right, is going to be sagging. He's going to be down. When he places his leg on, his weight on the right leg. Okay, so why is this going to make sense? Or what's going to happen here? So let's go to the questions, or the answer choices. Left gluteus maximus, right? Well, we know gluteus maximus is for extension of the leg. And a sagging pelvis comes from abduction of the leg. So we know this is wrong. A left gluteus medius, maybe. A left gluteus minimus, maybe, because both of these guys help with abduction. A right gluteus maximus, no, you could already eliminate him because why? Gluteus maximus does extension. What about a right gluteus minimus? Maybe. Okay. Now, if I was just taking the test, I would probably pick E because left gluteus medius and left gluteus minimus do the same exact function with abduction. And since they're both answer choices, I'm going to have to go with the right one. But let me explain why in the Trendelenburg sign, why it's the right one instead of the left one. Okay, so Trendelenburg side, if they say the left leg is the one that's affected, right, that's sagging, not affected. If the left leg is sagging, that means the right leg is the one that's affected. If the right leg is sagging, the left leg is affected. It's contralateral. So it's opposites. Why is this? Okay, so the gluteus maximus and the gluteus medius and the gluteus minimus on the right side, right? Since they're affected by the nerve, they're pulling tight, right? They're pulling tight. They're not allowing the leg to abduct. So if the leg on the right side can't abduct, he's not going lower to the ground. Because, like an angle, you have a straight line, right? And then if you go like this, right, on an angle, this is the longest point, this X, Y and Z are shorter. So if the leg comes out, right, the leg is usually in this position, right, this X position. But when it goes out, the position becomes like this. Okay, so he would get technically shorter to the ground, right, because this would be the longest point. So if he got shorter to the ground, what occurs? Well, the legs would be in an even plane. But since he's not abducting and he's staying straight in a straight alignment, this guy, when he moves, he's going to be down. He's going to be lower because this guy's standing straight up. So if he's standing straight up, the left leg is affected. Thus saying, the right gluteus minimus is the affected muscle. Okay. Now, number 9. A 45-year-old cleaning lady who scrubs floors on her knees visits the clinic with complaint of irritation in the knee. Okay, you see this? You should know it's got something to do with bursitis or something with her knee because she's on the floor scrubbing. Her skin is always rubbing against the ground. And that usually causes bursitis. Okay, but let's continue. Complaint of irritation in the knee. The examination revealed a septic bursitis. Okay, so it already says bursitis of housemaid's knee. This is a syndrome. If you know this syndrome, you could determine which patellar is or which region of the patellar is damaged. But if you don't, let's go through all of them. Which of the following bursae is most likely involved? Okay, so we're going to start off with the Anserini, right? The pes Anserini. This one is going to be, let me draw the knee for you, guys. Let me draw the knee region. Okay, so if this is the patella, right? The best picture I have of patella. And then I'm going to draw the tendon. So patellar tendon, right? It's going up top and below it, right? Okay, so above the top one is going to be the suprapatellar, right? Bursa. Below it is going to be the infrapatellar bursa. The middle is going to be the prepatellar bursa, right? This is going to cause Popeye's knee. That's what they call it. I don't know. And then below that, or kind of like medial, is going to be the pes anserinus, right? This bursa. So this bursa, right, kind of just gains a lot of fluid with daily activities and stuff. If he gains a lot of fluid, then he's going to have difficulty with the person walking and stuff like that, and he's going to cause swelling. He's not going to have anything to do when you're kneeling on the ground. When you're kneeling, so say this is your leg, right? This is your foot. If you're kneeling, this region is what? Well, this region is going to be rubbed on the ground, and this is going to be your patella. Your patella is on the ground. So your patella is going to be rubbing against the ground, and you're going to cause inflammation. You're not going to cause any fluid buildup on the medial side, so Anserini is going to be wrong. What about deep infrapatellar? All right, well, the deep infrapatellar is similar to the normal infrapatellar. He's just a deeper version of it, and since he's not on the ground, he's really not going to build any fluid either. Or he's not going to build any bursitis. How would he build a bursitis? Well, if this guy is on the ground, or if this guy's walking, right, you're going to get a lot of swelling and fluid in the kneecap, also known as clergyman's knee. This is just inflamed knee, kind of, and this is from just daily functions, I don't know. That's just how it comes. It's swelling around the knee. Now, the next one. So he's going to be wrong. Deep infrapatellar. Prepatellar. What is this guy? Okay, what did we say? Where is prepatellar? Prepatellar is literally on top of the kneecaps, on top of the patella. So if he's constantly rubbing on the ground, he's going to cause bursitis, he's going to cause inflammation. Housemaid's knee, she's always on the ground, or he's always on the ground, it depends. And they're going to be causing a disruption. This is going to be the answer, prepatellar. Subcutaneous infrapatellar. So what is this going to be? Subcutaneous infrapatellar. He's just below the skin, and he's in the infrapatellar region as well. So infrapatellar is wrong if you see that. And then suprapatellar, right above, also not on the floor, so that's wrong as well. Subcutaneous infrapatellar bursitis, however, so we could talk about them real quick before I move on. This one right here. This is caused by friction between the skin and the tibial tuberosity. So the skin and the tibial tuberosity, so something on the tibia, and the tibia has a tuberosity on it. And this causes edema. It's on the proximal end, so you know you have proximal and distal. It's on the proximal end, not the distal end. That's subcutaneous infrapatellar bursitis. Now, suprapatellar bursitis is caused by abrasions or penetrating wounds, right? So someone suprapatellar is above, I'm sorry. So if you get wounded, right, above the kneecap, or it's penetrated, what's going to happen? Well, you could get an infection and it's going to spread to the knee joint. That would be suprapatellar bursitis. But housemaid's knee, what we talked about, prepatellar. Okay, so now I'm going to go over 10. Number 10, we're going to have what? During a physical examination, the physician notes an absent biceps tendon reflex. Okay. Which spinal cord level is associated with this tendon reflex? Okay, so what are we thinking of here? So I know this is repetitive, and you probably already know this, but if you want to skip through, go for it. I'm just going to break down the brachial plexus one more time. So you have C5, C6, C7, C8, and T1, right? So these nerves are going to be the main vertebrae that are going to help with the upper arm, the upper limb. So C5 and C6 are going to form together, right? They're going to be roots. Let's remember the acronym. Remember to drink cold beer. Okay, so roots, right? So C5 and C6 are going to converge at the roots, and they're going to form the trunk. What trunk are they going to form? They're going to form the upper trunk. And they're going to branch into two divisions, a superior and an inferior. So I'm just going to write S and I, right? And then what's going to happen? C7 is going to be its own guy, right? He's going to form the middle trunk. Middle. And then C8 and C1 are going to converge, and they're going to form the lower. So he's going to form the lower trunk, right? Well, the middle guy, he's going to go superior, inferior into divisions. Lower is going to do superior, inferior division. Okay. So now, all of the inferior ones, right? Or the posterior ones, I'm sorry. Posterior ones. All the posterior divisions are going to meet. And they're going to form one cord, right? The superior ones of C5 and C7 and C6, they're going to converge, and they're going to make their own cord. Okay. They're going to be the lateral cord. He's going to be the posterior cord. So lateral, posterior. What does this mean, lateral and posterior? It's lateral and posterior to the axilla. Okay. And now the last one is going to be the lower cord. Okay, so how is he going to be made? Let me go here, different color. So he's going to kind of be by himself, right? And he's going to form the last cord, the medial cord, right? The medial cord is going to branch off into two different divisions as well. He's going to branch off. Okay, so now the lateral cord branches off into its own branches. What are the branches? Main one to know, musculocutaneous. Right? Posterior is going to branch off into two different ones. He's going to be the radial nerve. And he's also going to be the, which one? Axillary, I'm sorry. Axillary nerve. Okay, so now the medial one's going to branch off into two divisions too. What is he going to branch off into? Well, he's going to stay as the median nerve, but he's also going to branch into the ulnar nerve. Okay, so now we have that. So if we go back to the question, during a physical examination, the physician notes an absent biceps tendon reflex. Okay, so we need to know that the musculocutaneous division, right? He stimulates the coracobrachialis, the brachialis, and the brachioradialis. I have another video on discussing the whole entire brachial plexus in more detailed, but I'm just going to do this quick. So what do these three muscles do? They aid in the biceps flexion. Flexion of the biceps, right? So if you're trying to flex the biceps, what are you going to do? Well, you're going to use this musculocutaneous nerve. Where's he coming from? Well, if you follow him all the way back, he's mainly coming from C5 and C6. A little C7 innervation, but mainly C5 and C6. So if you have an absent biceps tendon reflex, you're going to know C5 and C6 is your answer. What is C4 and C5 for? Well, they're not for the brachial plexus, so you could cross them off. What about C6 or C7? Well, you could do the triceps reflex test with this guy. C7 or C8, it's too broad, so you're going to cross him off. And C8 to T1, what is he going to be responsible for? Well, C8 to T1 is basically the ulnar nerve. So anything to do with the ulnar, but we're talking about the biceps, so we know our answer is musculocutaneous, C5 and C6. Now, an 80-year-old man presents to the ER with a complaint of pain in the right shoulder. Okay, so something's wrong with his right shoulder. The pain is especially acute upon abduction. Okay, what is abduction? So if here's the body, right? Here's the arm. We're going away from the body. Adduction would be adding to the body, but we're going away, so we're abduction, this one. Okay, the examination reveals intramuscular inflammation. Okay, so something in the muscle, and is spread over the head of the humerus. Oh boy. Which of the following structures is most likely inflamed? All right, so I'm going to erase this guy. We know it's abduction. Okay. I'm going to draw a humerus, right? I'm going to try to draw my best to draw a humerus. Okay, and we know this is the head of the humerus right here, right? This is the neck of the humerus. This is the surgical neck. On the humerus, we have a greater trochanter. A greater tubercle and a lesser tubercle. The trochanters are for the leg. Okay. Then I'm going to also draw the scapula. I'm going to try to draw a scapula. Let's see what we got. We go down, go a little circle, come out. All right, it's not bad. There's a scapula. Okay. So we know that there's something wrong with abduction. So we need to know that there's two main muscles involved with abduction. And we know it's the supraspinatus and the deltoid. Okay, so if we have a problem with one of these, we could automatically have an answer, right? If we have a disorder or we're getting inflammation in something that abducts the arm, we know it could either be supraspinatus or the deltoid. So let's see the answer choices. Biceps brachii tendon. Well, that's not one of those, so no. Teres minor, teres major, infraspinatus, or subdeltoid bursa. So unfortunately, none of them are the answer choices. So we have to keep going. Okay, so what do I know? Well, I know that there's something called the sits muscle, or the sits, right? And this is where the supraspinatus comes from. So you have that's a bad color. We're going to have a supraspinatus. This is going to be the rotator cuff muscles. So you're going to have a supraspinatus, an infraspinatus. You're going to have a teres minor, not major, a teres minor. And you're going to have a subscapularis. Okay. But where do these muscles insert? So if these muscles, right, or if this is the scapula, you have the rotator cuff muscles right by it. So on the top, you're going to have the supraspinatus. But you know supraspinatus is not involved, but we could still draw him. He connects to the greater tubercle. Okay. Infraspinatus is below him. He also connects to the greater tubercle. Teres minor, below him, also connects to the greater tubercle. Okay. Subscapularis, he's below. You can draw him in pink on the anterior side. He, however, connects to the lesser tubercle. Okay, so do we have anything going over really the head of the humerus? Well, not really, because these muscles go to the tubercles. So we could cross out all of the sits muscles. So let me erase that. All of those sits muscles can be eliminated from our answer choices because none of them go over the head of the humerus. No. Let's see if we could do that. Okay, good. So what are the sits muscles? Supraspinatus, wrong. Infraspinatus, wrong. So we cross them out. Teres minor, nope. Cross him out. Teres major, well, that's not part of it, so no. Subscapularis, well, it's not even in the choices. Okay, so let's move on. What else? The first choice, biceps brachii tendon. Well, where is he? Well, you have the biceps, right? And you have the tendon that goes right between the tubercles. And what goes over him? Well, going across him is the transverse ligament. But is he going to the head of the humerus? No. So if he's not going to the head of humerus, he's wrong too. Oh boy. So we're going down the list. Teres major muscle, right? Similar to the teres minor. Well, not similar, but same family. And he connects to the shaft of the humerus. So if he's connecting to the shaft of the humerus, well, he's wrong too. So our only answer is a subdeltoid bursa. But what is this? Okay, so now if I draw, I'm going to attempt to draw the bursa as in like the subdeltoid first. I'm going to draw the deltoid muscle first. See if you guys understand it. And then if not, I'm just going to draw the bursa in between. See if it looks good. Okay, so the deltoid goes like this, right? This is the deltoid muscle. Deltoid muscle, right? He inserts into the humerus, right? And what does he do? Well, he aids in abduction, so he's pulling the arm away, so he's going this way. But what's in between them? Well, you have a bursa in between it. So let me draw the bursa in green, light green. So the bursa, right, is like this little fluid cavity, right, in between. So now, if the shoulder cannot do abduction, right, every time it is down by the arm, it is compressing to the body via adduction, right, adding to the body. So if he's compressing, what's happening? Well, that bursa is also being compressed. And if this bursa is being compressed, he's going to be by the head of the humerus. What are we having trouble with? Well, we're having inflammation that's coming from the deltoid going into the bursa. So the bursa that's over the head of the humerus is the subdeltoid bursa, and he's getting the inflammation. So he's the answer. I know that was a lot, but I thought it would be best to explain it like that. So now, last one, or another one. An 18-year-old golfer presents to the ER with a complaint of numbness over his medial hand. Okay. The examination also reveals the atrophy of the hypothenar muscles. The X-ray revealed medial humeral epicondyle injury. Well, this should make your eyes light up. Oh, no, not bad color. If you see this, you should know. Boom, I already know the answer. But if you don't, we could talk about it. So now I'm going to attempt to draw the hand. Okay, so that's that. Fingers, and the thumb. Okay, so this is the medial side. It's the lateral side. This is the medial side. Right, in anatomical position, the pinky's always in the medial, thumb's on lateral. Okay. Hypothenar is what? Well, the hypothenar region is the muscles by the pinky. The thenar is the muscles by the thumb. Okay. But we still don't have the answer here. We have something wrong with the medial humeral epicondyle. Okay, so the medial is going to be right over here. This is going to be the medial epicondyle. This is going to be the lateral epicondyle. Okay, but we still don't have an answer. So let's go through the choices. Anterior interosseous. Well, this is a muscle, so no. Musculocutaneous. Well, above I said musculocutaneous is for what? The biceps. So that has nothing to do with the hand. So no. Recurrent branch of the median nerve. Well, maybe. Superficial radial. Maybe. Ulnar. Maybe. Okay. So let's start with the recurrent branch of the median nerve. What is he going to do? Well, he's going to go down the middle of the arm, and he's going to go to the hand, but he's not really going to go over the medial epicondyle. So the injury is at the medial epicondyle, so that's wrong. The superficial radial, well, he's going to be more posteriorly, and he's going to be a little more laterally, and he's going to help with extension of the forearm. So he's going to be wrong. The ulnar nerve, this is the baseball injury, UCL tears, right? You tear the ulnar collateral ligament. It's going to be on the medial side of the elbow. He's going to cross over this medial epicondyle, and he's going to go down into the hand. He's also going to innervate the first, second, and a half digits, which is why you see the numbness over the medial hand. You also see atrophy of the hypothenar muscles, which we said was right here. So the ulnar nerve is going to be your answer. Okay, so number 13, a 50-year-old male is admitted to the emergency department due to severe back pain in the last few weeks. Okay, something wrong with his back. MRI examination reveals anterior dislocation of the body of the L5 vertebrae. Anterior dislocation, L5 vertebra. Okay. Upon the sacrum. Okay, so whatever. Which of the following can be possible cause for the patient's symptoms? Okay, so he has back pain. Okay, so something's wrong with his back. Anterior location. Okay, so let's draw... I'm going to try to draw a vertebrae for you guys. Okay, right? And in the vertebrae, right, we have the vertebral column. And behind the column, you have a spine, right? The vertebral spine. Okay, so now, what occurs? There's 5 different choices. You have scoliosis, which is possible, lordosis, herniated disc, spondylosis, or spondylolisthesis. Okay, what is the answer? Okay, so this is just a side view. I'm going to draw a view straight posteriorly, right? Okay, so a posterior view of the spinal cord. Okay, so what is scoliosis? Scoliosis is when the spinal cord is not really straight, so it's going to look like this. Look like that, right? This is going to be scoliosis. So, scoliosis, and then it says anterior dislocation. So this is like a lateral or like a medial dislocation, right? So scoliosis would not be right because it's got to be anterior. So scoliosis is wrong. Now, what's lordosis? Okay, well, lordosis and kyphosis kind of like go together. What are they? So let me just talk about that. So what is, when you're born, right, your body, this is what your spinal cord looks like. It's a primary structure, or the primary curvature, I'm sorry. Primary curvature, right? Your spinal cord is like rounded because you're just like hunched over in the womb. You're just like leaned over, you're hunched over. So this is a hunched look. This is the person's head, right? This is really bad, but that's the person's head. This is a primary curvature. Now, as you mature, as you grow older, your spinal cord starts to develop. So this is how it's going to develop. It's going to be like that, and like this. Okay, and then this is the head, right? So the spinal cord's going to have like grooves. So your back, your lumbar side is going to be like inward a little bit. We know that. We know what else is going to be inward a little bit. Our cervical area, right? Our neck, you want it to be a little inferior. And then the back, right? The thorax region, it's going to be out a little bit. You're going to be like protruded out a little bit. And the sacral region is going to be protruded out a little bit. Okay, so this is how we make our spinal cord curves. So whenever the structures are like going out, like in an outward curve, it's going to be known as kyphosis. So this is going to be kyphosis. And this is going to be kyphosis. And kyphosis is what is it called? It's a outer curve, right? So if it's an outer curve, just like here as a fetus, it's a primary curvature. Okay, and now how do you distinguish which one is which? Well, if this is the T vertebrae, this is going to be a thoracic kyphosis. Okay. What about the bottom one? If this is the sacral vertebrae, this is going to be sacral kyphosis. All right, good. Now, you have, if it goes inwards, it's called a lordosis. Okay, lordosis. There's 2 of them. If it's by the cervical region, it's called cervical lordosis. And this is not a primary curve, it's going to be known as a secondary curve. And if it's by the lumbar, it's going to be called lumbar lordosis. Okay, that's just something good to remember. So a kyphosis is a hunchback, and a lordosis, right, is the going inward. You're anteriorly displaced too much. Okay, however, what do we say? A 50-year-old male is admitted to the emergency department due to back pain since the last few weeks, MRI, anterior dislocation of the body of the L5 vertebra. Okay, so we go to the vertebrae, right? But this is the whole entire lumbar. So this is L1, L2, L3, L4, and L5. This is not one single vertebra. It's all of them. So the answer can't be lordosis because lordosis would be all the vertebrae, all the lumbar vertebrae, not just one of them. So that's wrong. What's a herniated disc? So we have like discs, right, in between our spinal column. And if one of them gets slipped or pulled out, as known as a slip disc, you could get a hernia. Well, that has nothing to do with the vertebrae, so that's wrong too. Now, this is where we come into spondylosis or spondylolisthesis. I cannot pronounce, I know. Okay, spondylosis, right? Spondylolysis, I think. What is he going to be? So he's going to be a fracture in the spine, right? So if you have a fracture, what's going to occur here? Well, a fracture is really just going to cause, there's going to be problems. It's a stress fracture for the superior region and the inferior region, right? Of the pars interarticularis, I'm pretty sure it's called. Pars interarticularis is over here. And this fracture is going to lead eventually to a complete break of the spine. So if there's a fracture, it's called spondylolysis. It's just a fracture. However, when this spine, right, after this fracture becomes a full-on break, this is going to be known as spondylolisthesis, right? And when that happens, the vertebrae gets pushed anteriorly, so it's a forward displacement, and this is going to be known as spondylolisthesis. This is going to cause a lot of back pain. This is after spondylolysis occurs. So after this fracture becomes a full fracture, then it becomes spondylolisthesis. So this is the answer. Okay, next one. A 25-year-old man is brought to the emergency department after a car crash. Okay. Radiographic examination reveals a whiplash injury. Okay. Hyperextension of the cervical spine. Okay. What ligament is going to be damaged? Okay. How are we going to talk about this? So I'm going to try to draw a head. That's a really bad nose. The lips, chin, right? Okay. It's an ugly face. Okay, and this is the spinal cord, right, coming down. Okay, so whiplash is when the head snaps back, right? When the head snaps back and then snaps forward. Okay, whiplash usually definitely causes hyperextension. So you hyperextend the anterior part of the neck. Okay, so if you're hyperextending the anterior part of the neck, what ligament are you going to be injuring? Okay, so if we're talking about the vertebrae, I'm going to draw one more vertebrae for you guys, an enlarged version. And you have the vertebral column, right? Like that. And attached from the vertebral column, you have the spine. The spine. Okay, so going through, what do we have? We have a couple different ligaments that go through the spinal cord. But I'm just going to talk about, kind of just the main ones, I would say. I would go through them all, but this is supposed to be a short video. It's going longer than it's supposed to, but that's fine. So the first one. 1 second. Let me get out this pen. Okay. So the anterior, right? This is going to be the anterior side. And this is going to be the posterior side. Okay, obviously. So the ligament that's running on the anterior side is going to be called as the anterior ligament. Okay, the posterior longitudinal ligament is going to be running where? Posterior side of the vertebrae. Okay, so you have anterior and posterior. Now you're going to also have the ligamentum nuchae. So what is the ligamentum nuchae? Well, he is another ligament that's running through the spinal column, but through the spinal cord now. Okay. You also have the infraspinous ligament, which is going to be running through the infraspinous column. And then behind him, you're going to have the supraspinous column. So the supraspinous is going to be behind him. Okay, and the nucleus pulposus, he's just going to be in between the vertebral columns. Okay, so if the head snaps back in this direction, right? It goes back that way. It's hyperextending the neck. This ligament is the one that's being damaged. The front one, the first one, the anterior ligament's being damaged. These three guys are all kind of supporting each other, so, they would be damaged, but this is the first one who's going to get damaged. He's on his own, he's in the front, and this is where the hyperextension takes place. So the answer is going to be the anterior longitudinal ligament. Now, what else could we talk about? We could talk about question 15, sorry. A 32-year-old patient visits his primary physician with complaint of fever and neck stiffness. So something's wrong with his neck. Patient complains of weakness, headache, and sensitivity. Okay? Headache, sensitivity, weakness to bright light. Based on the symptoms, lumbar puncture was performed. Okay, so they did a lumbar puncture. What vertebrae do they do the lumbar puncture at? Okay, so none of this matters. This is all irrelevant. We just need to know the lumbar puncture. So if we draw the vertebrae, 1, 2, 3, I'm going to draw a couple of them. And I'm going to go, let's see what we could do. 4, 5, 1, 3, 2. Okay, so this is L1, L2, L3, 4, 5, S1. Okay, the spinal column for adults ends around the bottom of L1, right? Kind of to L2. So the safest place to do a lumbar puncture is going to be in between L4 and L5. How are you going to know where to do this lumbar puncture? So if you have the sacral bone, right, and the sacral bone's got a femur getting attached to him, you go to the anterior part of the femur, right, and you go directly to where their belly button is. So if you were going to the front of the body, the belly button, you go on an angle to the belly button. Right in this region, right over here, is this going to be this L4, L5 region. So the lumbar puncture is going to be through the L4, L5. So this is going to be your answer. Okay, 16, almost there. A 67-year-old man has a restricted diet that includes Okay, I don't know who wrote that question. Okay, let's start it again. A 67-year-old man has a restricted diet that includes no fresh citrus, fruits, or leafy green vegetables. His teeth are loose and his gums bleed easily. Okay, so loose teeth, gums bleed easily. You should already know what this is going to be. You should know that this disorder is called scurvy. Okay, the patient's disorder most likely results from a defect in collagen synthesis. Okay, we know scurvy is collagen synthesis. That involves which of the following amino acids? Okay, so say you didn't know that it was scurvy, right? How can we break this down? Okay, well, before that, I want to tell you how I remember it's scurvy. I remember scurvy as like R for pirates, like scurvy. I don't know why. I just think of pirates when I think of scurvy. And I know pirates live on a ship, so they eat a lot of processed and canned food. So they're not really going to have fresh citrus fruits, and they're really not going to have a lot of leafy green vegetables in their diet. So if you look at a pirate's teeth, it's really, they have bad teeth. They usually don't even have teeth. They have gold fake teeth. And their gums are going to bleed easily as well. But how can we get this? How can we figure out this is what the problem was? So, collagen synthesis, we have to remember that there's a couple steps, 7 technically. So what's going to happen first? So you're going to form a pro-alpha chain, right? So formation of pro-alpha chains. And this is going to be in the cell or in the nucleus. And then it's going to go into the rough endoplasmic reticulum, right? So it goes into the rough endoplasmic reticulum. Step 2, it gets hydroxylation. That's step 2. Let's write hydroxy. Glycosylation is step 3, right? Step 4 gets released out as mature collagen. Mature collagen goes to the Golgi. So 4 is mature collagen, mature. Step 5 is the Golgi. What is mature collagen? It just has the C disulfide bonds on the sides, right? It goes to the Golgi, it gets packaged, leaves the Golgi, right? When it leaves the Golgi, the NC terminuses, they get cleaved. What is this going to be? Okay, extracellular cleavage. So cleavage. This cleavage is then going to go to step 6, which is going to be the formation of collagen fibers. Okay, formation of collagen fibrils, fibrils. After that, what's going to occur? I have a longer YouTube video on this, but this is just a quick rundown. This is going to do cross-link formation. Okay, and then this is how you're going to form collagen. But now, we have a problem with something with scurvy, right? Well, citrus fruits and green leafy vegetables does something. Okay, so when we're taking collagen and we're hydroxylating it, so we're adding an OH group to it, we're trying to give it more OHs, hydroxylation, we need a certain enzyme. What's this enzyme going to be? Well, we're going to hydroxylate a lysine molecule, or a proline or a lysine molecule, and hydroxyproline is the one we're going to use. We're going to turn proline into hydroxyproline. How? We're going to hydroxylate it. What are we going to use? Okay, so we're going to use an enzyme, and then that enzyme is going to need a cofactor. What's the cofactor going to be? So the cofactor is going to be vitamin C, also known as ascorbic acid, plus oxygen, plus iron. Okay, so if you don't have vitamin C or ascorbic acid, you can't form hydroxyproline. If you can't form that, you're going to have a type 1 collagen deficiency, which is going to lead to, I don't even know if it's type 1. You're going to have a collagen deficiency, and it's going to lead to scurvy. Okay, this scurvy is loose teeth and gums bleed. Okay, but it's asking for what? The defect in collagen synthesis involves what amino acid? Okay, well, we said we need hydroxyproline, so if we can't make hydroxyproline, we're going to have a deficiency in this amino acid. So hydroxyproline is going to be your answer. Now, another way that I remember scurvy, or how I know vitamin C comes, how do I remember vitamin C? So if you want to hydroxylate something, what do you want to do? You want to hydrate. If you want to hydrate, what do? Okay, it's the summer, you want to drink, I don't know why, I think of lemonade. Lemonade made up of lemons, right? Lemon plus water. Okay, hydration. Lemons have what in them? Well, it's a citrus fruit. What do citrus fruits have in them? Well, they have vitamin C. So this vitamin C could be used to hydroxylate proline to make hydroxyproline. So that's how you get this answer. Now, which of the following most likely decreases in length during the contraction of a skeletal muscle fiber? Okay, so what is this? Skeletal muscle fiber contraction is from the A bands and the H bands, right? The H band, it's from myosin and actin. So we have an H band. I'm going to draw it for you. The pink right here, this is going to be myosin. Okay, myosin is what? A thick filament. Then we're going to also have a Z line. The Z lines are going to be on the outside. And Z lines do what? All they do is really hold actin to them. They're attached to actin. Okay. So we're going through the answer choices, right? So first we had thick filaments. Check. Right here. Thin filaments. Oh, well, now we have thin filaments. That's actin. Thin filaments. So we could check that off. Z lines. So the Z discs. Well, that's right there. So we could check that off. The I band and the A band. Well, let's draw them in. So what's the A band going to be? The A band is going to be the length from the end of the actin, end of the myosin, right? So right over here, all the way to the other side. This whole region is going to be known as the A band. Okay. And now the I band is going to be what? Well, the I band is going to be the length of, from the actin, right, to the myosin thing. This is going to be known as the I band of the sarcomere. Okay, so now, muscle contracts, right? We have these things down. A muscle contracts, right? So it decreases the length. When it contracts, it shortens. The muscle goes from being long to being short. Contraction, and moves the bone with it. Okay, is the A band of the sarcomere going to change? I don't know. How do you know what changes? Well, when a sarcomere contracts, what occurs? So it shortens. How? The Z lines, right here, right, are connected to the actin. I'm sorry, I shouldn't have drawn those lines. It'll confuse you. So the Z lines are on the outside border, but the actin now, what does he do? The actin attaches to the myosin, but he comes in, right? He forms a cross bridge. So when he forms a cross bridge, he comes closer to the M line. This is the M line. Okay. So is the myosin going to move at all? No. The myosin does not move at all. So does the A band move? No. So that's wrong. Thick filaments. We just said myosin. Is that going to change? No. Thick filaments don't change. Thin filaments. Do they change? Well, we said they do, but we don't say the actual entire filament changes, just their distance changes. So that's wrong. The Z discs of the sarcomere. Well, the Z discs are all connected, and they're vertically connected. So if they're moving horizontally or laterally, are they going to really change? No. The I band now, this is going to be your answer. Why? So when the actin moves closer to the M line, the I band is going to shorten. So the I band of the sarcomere is going to be the reason why, or is going to be your answer, I'm sorry. It's going to be your answer. Now, question 18. This is going to build on the question above. Several hours after death, the muscles of the body go into a state of contracture, even without action potential. Okay, so you don't need this, but the muscles are contracting. How? Which of the following explains the physiological basis of this condition? Okay, so when the muscles contract after death, it's called rigor mortis. Okay, but I thought the only way muscles contract is with an action potential. Yes, but after death, what happens? Okay, so when a muscle contracts, what occurs? The actin, right, on the heads on the actin bind to the M line. When this happens, the muscles contract, right? Okay, but when the muscles contract, you need them to relax. How are they going to relax? ATP comes, and he cleaves off the actin head on the myosin filament. How does he do this? He releases a phosphate and knocks him off. He becomes ADP, phosphate gets knocked off, the muscle relaxes. Okay, so now, if you don't have any more ATP available because you're dead, if you're dead, you can't form ATP, your muscles are going to remain contracted. This head is not going to become detached, so you're going to stay contracted. That's why A, loss of all ATP is going to be your answer. Self-firing of an action potential is not going to be an answer because, why? You can't fire an action potential when you're dead, but even if you can, this has to do with muscle contraction, not muscle relaxation. So that's wrong. Increased availability of calcium. Well, you might build up calcium, correct, but is that calcium going to do anything if it can't get detached? If the phosphate head can't get detached, is the calcium going to cause a contraction? No. So if the calcium can't cause a contraction, that's going to be wrong too. Why isn't it writing? Okay, muscle membrane is easily excitable. Well, it is, but if you don't have ATP or action potentials, it's not. And autolysis of muscle proteins, well, sure, the muscle proteins can die and get degraded, but you're still going to have some muscle proteins available, so they're still going to form a contraction, so that's going to be wrong too. So the answer is going to be A, loss of all ATP, rigor mortis. Last question, finally, right? Which of the following best explains the effects of stimulation of OPJ and rank L? So, what is OPJ and rank L? Well, OPJ is Osteoprogenitor Cell, right? So I'm going to draw a little guy. Pretty sure I took this little picture from Ninja Nerd, but I don't remember. Okay, need that. Okay, so he's going to be an osteoclast. I should draw it in a different color. If he's an osteoclast, and then he'll be an osteoblast, right? He wants an eye too. He has messed up eyes. Okay, now, osteoprogenitor cells, what do they do? Well, OPGs, right, stimulate something. What do they stimulate? Well, they stimulate osteoblasts. What do osteoblasts do? Well, osteoblasts build bone. So they're building bone. Okay, not bad. What do osteoclasts do? They're going to break down bone. Okay, but now it's talking about OPGs and rank Ls. What in the world are these things? So, first let's talk about rank L. So, what happens? An osteoblast, right? Or you have low calcium in the body. Low calcium in the blood is going to stimulate a response. This response is going to stimulate parathyroid hormone. Parathyroid hormone is going to say, yo, osteoblast, do something. Osteoblast is like, okay, well, there's low calcium, so what do you want me to do? You want me to build more bone? There's none. So he's like, all right, well, he releases rank, right? And osteoclast has a little rank ligand receptor on him, known as rank ligand. And rank is going to bind to the osteoclast. Why does the osteoclast not get activated? I couldn't tell you. I just know this is how it is activated via low calcium levels. Okay, so the osteoclast is like, all right, fine. If you want me to do all the work, like always, I'll do all the work. So he comes, and what does he do? he gets a bone. Right? He starts eating away at the bone. So he breaks down the bone. When he breaks down the bone, calcium is released. Okay, so if calcium is released, you have a reabsorption of calcium where? Into the bloodstream. Okay, so you know it's got to be reabsorption from Rankel. So it could be this one or it could be this one. So A is wrong because it's not a reabsorption or resorption, I'm sorry. And D is wrong. C is wrong because it's not resorption. I don't know why I can't pronounce that word. Okay, so now it's either B or D. Okay. What did we say osteoblasts do? They build bone. How? Osteoprogenitor cells tell osteoblasts, yo, let's go, let's get to work. So they're going to take calcium from the blood, right? And they're going to say, all right, if I'm going to build calcium, if I have calcium and I need to do something, what could I do? I could build some bone. So what am I going to do? I'm going to formation of bone. So formation. And then I'm putting the calcium into a bone, so that's formation of calcium. And resorption is taking calcium away from a bone. So that's osteoclast on Rankel. So this is your only option. Resorption from osteoprogenitor cells will never be the case because the only things that reabsorb calcium is osteoclasts. Okay, I know that was a super long video and I'm just as tired as you are, so I hope it helped.